The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, how to play a crowd.
I haven't met many doctors who don't like information about themselves.
That's Dr Liz Mullins, the Director of Medical Services for Bega Valley Health Service at the Southern New South Wales Local Health District. And I'm presenting her with a difficult scenario.
Sometimes the head of department or head of unit's put in a difficult position.
In this episode, how to attract the interest of busy medical staff. In today's scenario, an Executive Director of Clinical Governance and Quality holds another disappointing quarterly specialist craft group meeting. There are 34 specialists within this craft group, but only 5 attend the meeting. The director had worked with the head of the department to develop what looked like an interesting agenda, even arranging for the CEO to present an update on the hospital's performance. But the specialists who attended only seemed interested in personally lobbying the CEO on matters like resourcing and staffing. And they passively resisted any discussion on surgeon performance or patient outcomes, focusing instead on what was being done about a recent run of urinary tract infections in the emergency department. Dr Liz Mullins starts by explaining what issues are raised by this situation and what questions come to mind.
Well, I guess the issues really is this is an important meeting. It happens quarterly. You're expecting an invited 34 surgeons and the CE, so you think you've done a super job in making something tantalising for them to attend. But the reality would be from the N equals 5 is that this is not a particular interest or relevant. They don't see this as having particular relevance or interest. So I do think in that situation you need to be humble enough to say, okay, so why did this not work? Would be my first point of view. I found that it's extraordinary the value of the text the day before or the morning of to the doctors individually to remind them that there's a meeting that night. And I'm always amazed how grateful they are to say, look, thanks very much, I hadn't realised and I'll be there. And that certainly has improved meeting uptake. But I think there's a broader issue here about what's the purpose of the meeting. Now, there may be a purpose from a DMS's perspective and the chief executive's perspective, but I think you need to speak to a number of the surgeons to say, what would you like from a quarterly meeting to review things? And I do think there's a degree of humility in making sure that it's something that's mutually beneficial would be my first thought around all of this. And the things that they're worrying about, so the CE does a high-level performance measure of, all sorts of things. Most doctors actually don't understand what that's about, are usually too unlikely to ask for definitions, so they don't actually know what an NWAR is or whatever that might be. So a lot of those meetings, as I said, for the executive are super for us, but they actually don't mean anything to the doctors. And so I do think you need to go back and talk to a group of them and say, so we really think it's important to meet. We want to share information about outcomes. We want to share information generally and in a de-identified way, and you'll get your own information for your own CPD. But more broadly, if there are clinical issues that we need to sort out, this is the forum where we'd like to do. And although urinary tract infections in emergency department catheterisation sounds pretty small beans, that clearly worries them. And so I do think there needs to be a bit of a rethink about who this meeting is for, and if it's about engaging doctors, then it's got to be something about things that are relevant to them.
I think that raises a really important issue. So much of the information and reporting that we provide within hospitals goes up to the executive and then on to the board. But we give very, very little information back to the frontline clinicians. The nurses sometimes get trend reports that they put up on the wall in their meeting rooms, but the individual surgeons get very little information about how they perform compared with their peers or their craft groups. How do you work with the surgeons to try and raise awareness of the need for comparative performance and the value of it?
So I haven't met many doctors who don't like information about themselves. And so it's really providing them with what they would want to know. So the common ones are, and obviously this is urology, so unplanned returns to theatre, use of blood transfusions, rates of clot retention. They're the basic old-fashioned ACHS clinical indicators, I think, that first started in about 1990. And they're a bit sort of seen as old-fashioned these days, but they are still the cornerstone, I think, of what clinicians want to know. And then I would ask them, so how often does the robot break down? When can I not have a technician to run my robot, or wherever it might be? They will know in their own mind the things that they would want to know about. And so rather than us being terribly helpful and telling them what we think they should know, I think it's very important to ask them what they want us to collect and then provide that information. But you're absolutely right. Our boards are typically better informed than any of our clinicians because they get performance data, they get safety and quality data that's managed to within an inch of its life for the board, but we don't share that downwards. And that, I think, is such a missed opportunity. And I also think we need to write it in a way, and this is not meant to be patronising, so there's not all the jargon that we get used to in exec or in quality and safety, frankly, but it's written in a way that's understandable about what we're measuring, why we're measuring. And then ideally you could measure the group versus whatever benchmarks exist, whether it's ACHS peer organisations or whether you're part of a private group and you've got another group of people doing this. This is a large unit. And so there should be investment in that information that can be given to them, on a quarterly basis. And I'd be astounded if they weren't fascinated to see, if you've got 34 doctors, so you're going to have AA and AB after the whole alphabet, to look at patterns. You then exclude people who don't do much operating, and they're a separate group, David, as you know very well, to look at their outcomes. And then you need to look at what we're doing in terms of the types of procedures. And for surgery, this is pretty straightforward. This is a bit more challenging for physicians, but the endpoints in surgery are pretty easy to measure. So I would have thought that that's the approach, is to ask them what they'd like to measure. And if they don't know, give some suggestions. And in my experience, they're normally really interested to see about their own performance.
The chief executive turns to you after the meeting and say, that was a waste of time. I'm not going to take my time out to talk to 5 doctors, implying that this is your problem. Tell me about carrots and sticks. When would you bring in the sticks if you're not getting good attendance at your craft group meetings?
As I said, the word is humility, and that's not meant to in any way undermine the role of a director of medical services. But you've got to be smart. So you've actually, got to know who they are. Whether it's the jazzy phrase of Studer rounding, you need to go into the operating theatre when you know they're there. You need to have a chat to them. They need to know who you are. Now, I'm not talking about necessarily all 34, but presumably it's the 80-20 rule. And if you can speak to the 10 busiest urologists, they're the ones that you need to speak to. Sadly, I am aware of surgeons and physicians who never meet their director of medical services. And we can all spend our day in our offices doing all sorts of terribly important things, but the engagement word is actually a two-way street. And I think it's about us going out and engaging with those people in their place. So not to come to your office, to get into scrubs. Now, they'll have an all-day list, and in a month or 6 weeks, you can probably meet with all of them. They'll be very appreciative you've come into theatre, and you say, look, we're really keen to do this. We want you to get together, and this is a format we're looking to do. What else do you think we could do? I'm not sure that they value the chief executive the way the chief executive values themselves or the DMS values them.
Yep.
But I think it would be fair to say that what you really want is them working together with the DMS. And a good CE would be smart enough to pop into one of those meetings to say hello, because ideally they have a relationship as well, obviously a little bit more difficult. But when you've really got a CE who understands medical engagement and the importance of that, and there's a world of literature around that for all sorts of reasons, they actually need to do some engaging as well. And so that may be difficult for the DMS to negotiate with the CE, but I think the idea is that we have to actively engage with our doctors in addition to them coming is a very important philosophical underpinning of this process.
Liz, one of the individuals, I guess, in the middle here is the head of department. You sat down with them and planned the agenda. They obviously endorsed it and thought it would be good, and yet only 5 people turned up. Tell me how you're going to work with the head of department to ensure they're more effective, engage their peers and reflect, I guess, what's going to be a valuable meeting for their colleagues.
So, we go down to theories of leadership where there is formal leadership and informal leadership. This person may be formally the head of department, but was out of the room when it was voted on, or is the new boy or girl back from overseas and they're desperate for some work, so they took 4 hours a week to do this. And there may well be power or historical relationships that are going to make or break a unit. So I think you need to be, again, smart enough to say to the head of the unit, and if you know they only operate once in a while, then you would need to say, well, maybe we could have a group of some of the doctors who do more, who've been here a little longer, to work with that. So sometimes the head of department or head of unit's put in a difficult position because they're not considered the best, and so that undermines them from the very beginning. So I would view that a collaborative approach. Now, if they say, oh, look, I don't get on with Charlie Farley, and Charlie Farley does 40% of the operation, we've got a problem. So I think it's up to the DMS to say, well, let's have a meal, let's have a drink after work, let's meet once a month and catch up. I went to a negotiation course a long time ago with a group that did sort of not just medical, they did worldwide negotiations. They, arranged negotiations between Bolivia and Chile and those sorts of things. So very high end. And they had a mnemonic which has stayed with me forever, which is to meet early and meet often. And their philosophy was, and we see this play out, whether it's Bill Clinton and Tony Blair over the Northern Ireland Agreement, people negotiate with people they like. And part of that is to know who they are. And I think as a DMS, that's very much, and I'm not talking about becoming friends and sort of have a personal relationship, but I think you have to have a very cordial relationship with your heads of department. And that only comes from getting to know them and not necessarily talking about rosters, but catching up once a month. Now, in a big organisation, you'd be drinking a lot of coffee, but it may mean that your 7:30 to 8:30 meeting 3 times a week every month for your heads of department is really good investment, I think, in having a sense of where they are, what they're thinking. In this particular situation, I think you would need to make sure that it's not perhaps the head of department, if they're not particularly effective, then suggest that you meet with a couple of others together, not behind the head of department's back, but as more of a group around how do we improve and make sure urology has a voice at the table. You could craft it strategically to say, I'm going to be advocating for things and I need to understand your needs so I can advocate for them well. So that would be my approach to a head of department.
Thank you, Liz. The group has expressed discomfort talking about individual cases or individual clinicians' performance. How do you establish a culture of trust and confidence that allows peers to discuss their cases in an educative and constructive way?
It's very difficult, I think. The obstetricians have done this forever. They never have a perinatal meeting without the midwives, and they include paediatricians and they include anaesthetists, and they've been doing that for a very, very long time. I work in rural New South Wales and we still have M&M meetings where people are uncomfortable if a member of the nursing staff comes. And frankly, they're uncomfortable if I come as well. And so that's about, again, what's the purpose of this? It's not to witch hunt. It's to find out outcomes. And if you operate on a Friday and you have longer lengths of stay than someone who operates on a Tuesday, then that demonstrates that the reality of weekend support for post-operative care or whatever that might be. So I think M&Ms in the traditional model, and in New South Wales we have a very clear, organised process for M&Ms. I think you start with the doctors coming together to discuss them and moving from the specific to the general. So access to theatre after hours, access to anaesthetist, weekend, whatever that might be. They then get comfortable around that. And then when there are issues that relate to nursing staff or lack of allied health staff, it's not a giant leap to have them come to the next meeting, even if it's only for part of it, to feedback on what's been learned around that. But I think many of them have had an experience, or they have a friend who've had an experience where it's unpleasant. And that's where I think there is a role for the DMS to actually broker those conversations. I've been in places where the anaesthetists run all the M&Ms. So again, they're just the honest broker, if you like, to try and have the conversations work really well. But I do think if you force it too soon, then it won't work. And so I do think it's around evolution. I've been in places where I've invited the obstetrician to come to a general surgical M&M, and the obstetrician says, "Where are the nurses?" So it's a peer saying, how can you review these cases without the anaesthetist, without the nursing staff, without pathology? We would never think to do that. And that's been very helpful, because it's a peer talking to a peer saying, the sun comes up in the morning even if you have nursing staff at your peer review meeting.
We were exploring the issue that so often M&M meetings focus on historical disasters rather than taking a problem-focused approach to how can we avoid these complications in the future. How do you get the group to move away from sort of the name, blame and shame, oh my goodness, what did you do that for, towards let's work together and see if we can come up with a solution to make sure it doesn't happen again?
I think that's why there's a role for the DMS to facilitate those meetings. And it's not about wanting to control, but most of us hopefully are trained in seeing the system behind the individual. So, I would take the perspective, so let's assume that all of us, as in we surgeons, are all good at what we do. That's why we work here. So there may be an error of judgment. There may be a lack of knowledge. We know that's uncommon. What we do know is what are the system issues that underpin performance. So did you know you were on call? What's the quality of the surgical registrar? If they're not up to the mark, they're not calling you in appropriately. And that's not to take consultants off the hook, but I think it's very honest to say when you teach them to look systemically, they all of a sudden, because they're just completely narrow because it's them and the patient, and that's their job. But if you just get them to expand that vision to understanding why, if you speak badly to your registrar and belittle them all the time, don't think they're going to call you at 2:00 in the morning when someone's dying, and then you've got a disaster. So I do think the DMS has a role. Some surgeons, some physicians are very good at that. In my experience, they're not trained in it, but once you do take them through that journey, then that becomes something that they can all of a sudden see a little bit beyond the individual blame and shame.
I found one of the key successes to changing culture is success. That if you can have a meeting, identify a problem, work through a solution, and then come back later with that solution implemented, everybody's excited and they're keen to explore the next opportunity.
Which is why it's kind of tragic that, is it our job? I don't know. I'm a very pragmatic girl. You send a text. So you've got all of their numbers in your phone. Dear David, looking forward to seeing you at our quarterly meeting tomorrow night. Just a reminder, regards, Liz. Now, I tend to do it on the morning of the day because even 24 hours before gets lost in what they're doing. And I'm always surprised the number of, thanks for the reminder, Liz, see you there. And that's the case for medical staff council meetings. They don't live in front of their computer. They don't live in front of their diary like we do. And so a friendly reminder, looking forward to seeing you there, having a bit of food, makes it, I think, a worthwhile activity. Certainly for bigger medical engagements, so we've run a series of dinners where I work. They're all getting a certificate for 3 hours of participation in education and review, looking at our clinical services plan. Again, that's an administrative burden to an extent, but it's a way of saying thanks very much. And whether they use it or not doesn't matter. But I do think that two-way engagement and communication, and you're absolutely right. People saying, oh, God, I've never come to one of these. That was really interesting. And then when you have the CE talking about the challenges for the organisation or the budget constraint or what that means and sort of take them into their confidence, that's always very powerful as well.
So 3 months' time, next quarterly meeting, you get 6 attending, better than 5, realise it just hasn't worked. Where do you go for help?
Oh, I think you ask a colleague. I think you say, who do you know? Or first of all, I'd ask a colleague in a place that has a good reputation. I'm assuming most of these are VMOs, and I'd say to several of them, look, we've got 6, so that's a fabulous increase. When you work somewhere else, do you do this? Oh, yeah. And why do you go? Oh, well, da-da-da-da-da-da-da-da. So I think, again, you have to be humble enough to say you might not get it right the first time. And if say, well, actually, they used to do this during the evening and now it's done on a Saturday morning and no one minds because they're actually free from 8 till 9 and that's what we do. Or, you can't have it on a Saturday morning, but most people, Wednesday night, Tuesday afternoon is usually a non-event for most people. Try and do it there. Alternatively, you can do the meetings at 8 o'clock in the morning. I mean, in the United States, they would do all these meetings at 6 a.m. because that's just kind of how they are. But maybe it's 7 o'clock in the morning or 6:30 with breakfast, out by 7:30. Again, I would survey them. I'd write to them and say, we really want you to come. And, I use text a lot because they won't read emails. So I just send a text. Dear David, awfully disappointed we only had 6 out of 35. Just wondering if you could give me some thoughts on how we might make it more interesting or easier for people to attend. Now, when you're running a big tertiary hospital with 34 surgeons, that's a lot of time and commitment. But there are clever ways to send texts, and that's what I would do about really seeking to actively engage.
So you sit back. What are the success criteria that you would set yourself to determine whether or not this group of specialists is engaged?
Oh, I think it's got to be on the number of people who attend.
Right.
I mean, that's a cruel and like runs in cricket, Perfect work in the nets doesn't count for anything. So I think you have to have the number of people. I think you have to count the number of responses that you get in relation to what's going on. I think you need to say to yourself, well, in this month, how many urologists have I spoken to? How many times have I gone to theatre? And it may be that you don't do it for every single craft group, obviously, but, if November is going to be urology month, then that's where I'm going. And maybe you just have to calendar that over the year to make sure you're doing it. Ideally, and I think there are lots of measures of medical engagement, but I think in this situation, it would be attendance at a meeting that everyone considers to be worthwhile and slowly chip away at that.
Thanks very much, Liz. A huge challenge.
Oh, yeah. As I said, I think you've just got to find, your local champions. You need to speak to the boys, usually, that everyone looks up to and ask them to come. And hopefully you've built up some capital with relationships with those people to say it would be really important if you came, and I'd be really grateful if you could ask some of the other boys and girls to come. It's important. We know it's important. We want it to be valuable for you, but our job is to make sure that the work that's being done is safe and effective. And, if we're relying on coroner's cases as our only measure, that's not very good. We want to work with you to make a better service. And I think the opportunity to have the ear of the CE, for smart doctors, they understand that's really important in a competitive world where they're competing against orthopaedic surgeons or cardiologists or, whoever that might be. So I think strategically you can make it very clear this would be a good thing to do.
That was Dr. Liz Mullins, the Director of Medical Services for Bega Valley Health Service at the Southern New South Wales Local Health District. That brings us to the end of this episode of Safeguarding Healthcare. I'm Dr. David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.